Good afternoon. We're going to resume. First, we have a keynote lecture, Approach to Calcified Lesions, Dr. Fadi Al-Qaisi.
All right. Shukran, Dr. Ahmad. All right. So we are talking about a common problem, مشكلة بتواجهنا دائما, calcified lesions. This time, no cell phones. You can keep your cell phone in your pocket. No voting. I'm going to be a slower pace. So, scope of the problems. More and more calcified arteries we encounter. There is an advanced age population. There's multiple comorbidities of diabetes, chronic kidney disease, hypertension, smoking, family history. And the calcified arteries, they have special challenges. They have lower procedure rates. It's difficult to deliver equipment. This is the previous case we talked about it, how it's very difficult to deliver equipment around calcified lesions. We may end up with under-expansion of the stents. You may have complications of rupture or dissection. This is one of the cases. After I tried to post-dilate the stent, I ended up rupturing the artery. The patient survived. And there's late complication if you have under-expansion with stent thrombosis and stent restenosis. And we have special challenges in Jordan. في عمان في عنا تحدياتنا. لما نشوف الليجنز مثل هدول lesions تطلع, this is a typical case I encountered the other day. Shall I give it a try? Is it really that calcified? It may work. The patient is already here. دفع الدخول, دفع الباكج, وعندي على الطاولة. If I don't do it, هياخد الCD ويلف عمان, or somebody else will do it. If I try and don't succeed, شو بدي أحكي للعيلة برا. I tried, I opened equipment, شو هحكي لهم ما زبطت. What are my chances of success? And the most important challenge, I want to work it, but yet I don't want to leave behind me under-expanded stent. So how can we evaluate the artery and the degree of the calcifications? How can I know this is calcified artery, that I will succeed, or it's a very bad artery, I have a low chance to succeed? One of the nice tools, if the patient has a previous CT scan. Many patients, they have CT angiogram, you can look at the CT and appreciate the degree of the calcium. The other thing is fluoroscopy. Obviously, the best method is intravascular imaging, that we are going to talk about it in a second. Fluoroscopy is not very sensitive. We all here in the hall, we rely on fluoroscopy and our eyes. But the sensitivity is only 50%, specificity is 95%. And it is deceiving. These are two cases I encountered the other day. You cannot differentiate. What's the calcium? Is it superficial? Is it deep? Is it circumferential? What's the thickness? Is it all around the artery? Is there a nodule? I cannot tell. So these are two cases. You appreciate here, this is the left main. This is a very bad left main. You think, oh my gosh, this is tons of calcium. I cannot see the artery. And yet, when I did the IVUS for this case, you can see the calcium is only on one arc, one side of the artery. It's not that severe. Whereas this artery, you think, I can approach it. It's not a lot of calcium. This is his IVUS. It's circumferential calcium all over the place. I will not be able to crack this artery open with my traditional equipment. And that's why we must use our intravascular imaging to evaluate the extent of the calcium, the phenotype of the calcium, and to guide our choice of the modality to handle the calcium. The recent guidelines, they classify class 2A of using intravascular imaging. All of us, we have been in conferences, and every case, this is the IVUS, this is the OCT, this is the IVUS, this is the OCT. And when you compare it to pathology, it's a very accurate method. It has sensitivity and specificity more than 90%. What are our tools to use intravascular imaging? We have the OCT. The OCT is a very beautiful device. It's a small device. It moves inside a sheath. It does not have direct interaction with the artery. We do not have it in Jordan. The other one is the Volcano device. It's a bulky ultrasound that goes inside the artery, but it has its own movement and direct interaction with the artery. Sometimes it can hurt our arteries. The other ultrasound, which is beautiful ultrasound, the Boston Scientific ultrasound, it moves inside the sheath, very slick, very small, no interaction with the artery, and it just became available in Jordan. الخدمات زملائنا في الخدمات جابوه نستنى يخلصوا الجهاز وناخده من عندهم نصير نستخدمه برا. IVUS, everybody is familiar with the IVUS. It gives us this bright acoustic shadowing. It can measure the arc, it can measure the length, but not the thickness, because we cannot see beyond the calcium. It's very good for osteal lesions, and it does not need to use contrast to clear the artery. So it's great for chronic kidney disease patients and multiple usage. OCT, optical coherence tomography, although they give us superior high resolution studies, and it shows calcium as this heterogeneous, low backscatter, low attenuation. So IVUS, bright. OCT, dark. Low attenuation arteries. It can show, this is one of the cases I did, this is online images, and you can see this calcium all over the place, and it can show calcified nodules. It can measure the arc, the length, and most important, the thickness, which IVUS cannot do. It's not good for osteal because of the need of the use of the contrast and clearing the artery. So you cannot clear the artery for the osteal. And as you know, it needs contrast to clear the artery and get this nice black space, and you have to have good contrast washing, so it's not great for repeated use or for patients with chronic kidney disease. What to look for in general? When I do intravascular images, I saw the artery, I did fluoroscopy, I did the intravascular images. What I'm looking for? I'm looking for the arc, how circumferential is the calcium. I'm looking for the thickness, how thick is that calcium, how deep is that calcium. I'm looking for the length, how long the artery has calcium. I'm looking for any nasty calcified nodules. Those are nightmare for every interventional cardiologist. And then we can look for the arteries, the size of the artery. Is it less than 3.5 millimeters or not? And there are summary, very nice article from Sky that shows you all of these criteria. There is development of points based on OCT and based on IVUS, so you can make a decision. Shall I use plaque or calcium modification, or I don't need to use plaque calcium modifications? For each criteria, you can add 1 point. If you have 2 points and more, it is recommended to use plaque modification to get better results, including the arc, the degree, the length, the diameter, and the calcified nodules. All right, so I have the artery. I identified it's calcified. What should I do with this one? My goal is to decrease the burden of the calcium and to disrupt the calcium so I can increase the elasticity and allow that nice expansion of the artery to the proper size. So what are my tools to deal with calcified arteries? You have the compliant, non-compliant balloons. You have the specialized balloons, high pressure balloons, cutting balloons, scoring balloons, atherectomy devices, and intravascular lithotripsy. Let's go into details into each one of them. Compliant and non-compliant balloons, advantages on the left side, disadvantages on the right side. Advantages, it's available. It's low cost, it doesn't need any special skills. Disadvantages, it does not really deal better with more than mild calcium. It can manage mild calcium. Otherwise, you are going to end up with stent under expansion. It has the watermelon seed, بزحلق جوا الارتري, and it has the trick of eccentric expansion. Many of us rely, oh, look at the balloon, it expanded, that means I opened the plaque. Many times that's incorrect. You are expanding, favoring the adventitia, leaving the actual plaque itself, and that can risk your rupture and your perforation. High pressure balloons, we have it in Jordan, it's available. It has medium cost and clear the cost of close to the cost of the stent. It doesn't need any special skills. The disadvantage, it has low deliverability, it's bulky device, and obviously there is risk of perforation and rupture. The other devices, the specialized balloons. There are cutting balloons, scoring balloons. There is the balloon with the blades and different score flicks, angiosculpt, different balloons. Advantages, they are available. They are medium cost again, no special skills. There is more predictable interaction between the balloon and the plaque and the artery. And it does not have the watermelon seed because of this metal around the balloon that can capture on the calcium and the artery and continue expanding. Disadvantages, deliverability, again, they are bulky devices and they have limited effect on the actual calcium load. What are other equipments? Rotational atherectomy. Rotational atherectomy, it has advantage of very nice success rate. And it's actual modifications of the calcium. You are shaving the calcium. It is available in Jordan. It is available, the new generation, the Rota Pro, which is more operator friendly at this time. Unfortunately, this advantage is limited to our own market. It's not always available. You have to have a previous arrangement with the company to bring it to you. And you have to have predictability of that you are going to use the rotablation. High cost. You are talking about thousands of GDs when you are talking about rotablation. It needs special skills. It has special training, special pros and cons, and do's and don'ts for the rotational atherectomies. And it can lead to serious complications of no flow, dissection, perforation, Burr entrapment. This is our patient earlier with the calcifications of the artery, which, by the way, I did for him TAVI at the same time. And this is his IVUS. You can see the heavy calcium. I told the patient, I cannot do this with the regular balloons. I must do for you rotational atherectomy. And indeed, I did for him rotational atherectomies, and I got at the end relatively nice results with good expansion of the stent. Again, speaking of complications, not all the times it's nice equipment, because it's nice results. This is a patient I did for her rotational atherectomy. I ended up with some no reflow. At the end, finally, I got decent results at the end. But yet, they were very rough 30 minutes. The other device is orbital atherectomy. It shaves off the calcium again. It has high success rate. It's actual calcium modifications. It's not available in Jordan. It has high cost, needs special skills, and again, it has its own serious complications of no flow, vessel dissection, and crown entrapment. Many of the peripheral people, they like this more than the rotational atherectomy or the rotable. Laser atherectomy, high success rate, actual plaque modifications. It can work with any wire. It doesn't need special wire like the other two devices. It's not available in Jordan, and it's high cost, needs special skills. Intravascular lithotripsy. This is the new invention. It's beautiful equipment. It has a high success rate. It's actual plaque modifications of calcium modifications. It doesn't need any special skills, actually. It's not always available. إلى الآن الوكيل لسه ما جاب لنا إياهم مرة تانية. It needs previous arrangement. It needs high cost. It has deliverability. You have to have preparation of the artery to deliver the balloon. And it needs to tolerate the patient to tolerate long inflations. Otherwise, there is going to be some problems with the ischemia. This is a case for which I used lithotripsy in Jordan. And I did nice bifurcation. I used the same balloon on multiple arteries, so I can save the cost of one balloon. This is another example of a case I did in the US where there's a thick calcium according to the lithotripsy. According to the OCT with lithotripsy, you can see these cracks among the walls of the arteries. I disrupted the plaque so I can have proper expansion, and the stent sits very nicely. There is a very nice algorithm how to evaluate which equipment to use. For the sake of time, I will just pass and spend a few minutes to talk about Jordanian challenges. We have special challenges in Jordan. Unfortunately, number one challenge till now is cost. When you talk to the patient and you are telling them that the package altogether to put a stent is ranges between 3,500 5,000 dinar, فجأة double it. The patient will look at you like, من وين? He cannot afford it. And yet, that's why we hope for our partners in Jordan University, in الخدمات, في الصحة, يجيبوا هاي الايكويبمنتس، ينزلوا الكوست على الشركات حتى احنا نستفيد في الخاص، يصير يخففوا علينا، يطلعوا حق الايكويبمنت نفسها. فالكوست is still our challenge. The other thing is the availability. Unfortunately, we have few devices of rotablation or lithotripsy, and that's why they are sitting there. الوكيل بده ينقلهم من مستشفى لمستشفى، فأنت داخل تشتغل للمريض, you have to take them off the table and explain for them why you did not work on the artery because of the calcium and this and that. And then you have to make sure the understanding of the family. So that's why my suggestion as a team, as leaders of the intervention community, to have consistent messages, to tell the patients that this is what I did. My partner did this because of these causes, which I support his decision. Again, we have to be one voice, one message to the patient so they understand why they were taken off the table, why we are talking about higher costs, why we are talking about different equipments in their special cases. Thank you.
Thank you. We'll keep the questions till the end. Our next speaker is Dr. Ahmad Kamel from Egypt. He will be speaking about CABG versus PCI.
Good evening. First of all, I'd like to thank Dr. Zreik and the organizing committee for this invitation for this elegant meeting. So this is my case. I will go fast because I know we are short of time. This is an 80-year-old man, retired school teacher living in Tanta city. It's a big city in the north of Egypt. He's non-diabetic, hypertensive. He's complaining of recurrent attacks of typical angina on mild effort. So he was referred for coronary angiography in a local hospital. Then his angiography showed diffuse atherosclerosis and calcification in the LAD, proximal LAD, with severe proximal LAD stenosis. So the operator opted to stop at that point, and he had the opinion of CABG versus PCI. So the patient was referred to the National Heart Institute in Cairo. The heart team opted for PCI with rotablation, as the patient was old and frail. So this was his angio. As you can appreciate, severe calcification in the proximal LAD with very tight proximal stenosis. And as you can appreciate, the distal targets of the LAD, the target is very poor for surgery. So this was the heart team decision, PCI with rotablation. So this is what we did. We wired the LAD with a workhorse wire, and this is an over-the-wire balloon 2.0 in order to exchange for rota wire. So this is the rota wire, and we started rotation atherectomy with 1.5 Burr, many runs. Actually, we're planning to ablate the whole mid-LAD from proximal to the mid part, multiple runs of ablation, as you can see. So this is the angio after ablation. We have lost everything. We have lost the LCX, the LAD, severe dissection, patient has chest pain, and then he had cardiac arrest. So what I have done, I cut the rota wire, the long rota wire, and I inserted a stent 4.0 as long as it takes. It was, I think, 28, and I started to stent to secure the left main to seal the dissection. This is on CPR, as you can see. This is compressions, still compressing, and this is after we stented, still we are compressing, and this is still we are compressing, and now we had some pulses, and as you can appreciate, there is a distal to the stent, we have type 1 perforation in the LAD. So we have two complications, first dissection, and this is type 1 perforations. So will you stop at this point, or would you proceed? So I opted to proceed, and this is this is balloon dilatation distal to the stent in order to open any flow distal to this stent. As you can see, the wire was pulled out, but we managed to go down with the wire again. And as you can see here, we have some flow in the diagonals and the septals, promising. So we are going to open the distal LAD, the mid and distal, and to stent the whole vessel. So one of my colleagues told me that you're wiring in the false lumen, so I put another wire. It goes to the diagonal, so now I'm sure I'm in the true lumen. Now I have two wires, one in the diagonal and one in the LED, trying to park the distal end of the wire in the distal LED. Now I am okay, the wire is in. So this is balloon dilatation of the mid part of the LED, trying to open any flow distal to the stent that was deployed. Ballooning, this is a 2O balloon. Once, twice, third time at the bifurcation of the diagonal. So this is after we opened the LED with balloons. We have sluggish flow distally. So now I try to stent in order to secure the flow in the distal LED. This is a 2.5 millimeter stent by 28, I think. Still, we have the diagonal. We pulled out the wire, but the stent is open now. The proximal perforation is not seen at that time. And then we took another stent proximal, or between the two stents, the distal one and the proximal one. This is a midway stent in the LED. This was 3O by 18, overlapping with distal stent. Trying to have some overlap. And now this is the result after 3 stents. We have diagonals, we have septals, we have sluggish flow in the distal LED. And this was our final result. It's not the best, but the patient now has pulse, has some pressure. So the patient was transferred to the CCU, mechanically ventilated with small doses of intravenous noradrenaline. Intra-aortic balloon pump was inserted, and few hours later, maybe next morning, the patient was extubated, but the next day in the afternoon, the patient had ST elevation in the ECG, so we took him again for a control angio, and this was what we saw. The right coronary artery, actually, we didn't tackle the right coronary artery in the first procedure, but we wanted to see what's going on. So this is the right coronary artery. It's the same as it was before. We didn't treat it in the first procedure. And this is the LED. I think the flow is better. We have maybe TEMI 3 flow. The left main is okay. The perforation, the type 1 perforation in the proximal LED now is gone. No extravasation of the contrast. This is the spider view. As you can see, we have now the LCX. The LCX is okay. We have TEMI 3 flow on the LCX. And you can see the balloon pump. And this is a cranial view. We can see diagonals, septals. Patient has good blood pressure. The flow is better than before. This is the left cranial view. We have diagonal septals, TEMI 3 flow. So fortunately, there was nothing to be done at this procedure in the control angio. The patient was sent back to the CCU on intravenous adrenaline. Then it was weaned. One day after, the intra-aortic balloon pump was put off, and the patient was charged towards in few days after this incident, and he was back home in a week. So my take-home message is treating calcified coronary arteries is always a challenge to interventional cardiologists. Calcific lesions preparation before stenting is extremely important to allow stent expansion and prevent future stent failure, which is stent thrombosis and in-stent restenosis. So we have many tools, and Dr. Fadi Qaisi said we have many tools that can be used to treat or predilate calcific lesions, cutting, scoring balloons, non-compliant OPN balloons, atherectomy, whether rotational or orbital, IVL. So an expert interventional cardiologist should know which tool to use in which case. Of course, IVUS and OCT are mandatory, but my last message is whatever happened, left main dissection, as we had in this case, left main dissection, cardiac arrest twice, LD perforation, please don't panic. So this was my case, and thank you, and ready for any questions.
Thank you. We'll defer the questions till the end. Our next speaker will be Dr. Hussam Suradi. He will be talking about Burr entrapment.
Okay, good evening. So staying within the theme of rotablator, rotational atherectomy, and the nightmares that can be encountered, this is one of the nightmares that we hope that we never would see, but you know, if you are doing rotational atherectomy, you need to be aware of this potential complication and know how to manage it. Great case by Dr. Ahmad Kamel, a really great save for the patient, so congratulations. So our patient is an 84-year-old lady who presented to the hospital with anginal chest pain, ruled in for non-STEMI. She has past medical history of HFpEF, diabetes mellitus, and stage D3 aortic stenosis. This case actually was performed by my colleague, but I was pulled in and called in to help with a complication that you'll see here shortly. So this is the diagnostic angiogram. As you can see, there's severe critical lesion involving the left main, both in the ostium as well as in the mid to distal vessel. Circ was relatively okay. The proximate LAD was had some diffuse disease in that segment. Again, you appreciate the calcification within the left main and some involvement of the ostial LAD and probably some of in the ostial circ. Was a non-dominant RCA, and this is her echo with normal LV function, and she had a paradoxical low flow, low grade in aortic stenosis. So patient was taken off the table, and we had a heart team discussion. She was offered surgery, but patient refused to undergo surgery. And actually, my colleague had really an interesting conversation with the surgeons at that point, and the surgeons were so unhappy. They said, like, if anything happens during the PCI, we are not willing to bail you out. So you're on your own. So that wasn't a good start to start with. So in order to plan her for the procedure, we did some hemodynamic assessment. First, to really assess, the severity of the aortic valve. On the echo, it looked really restricted, although the gradient were not high, and it turned out to be more consistent with the stage D3. Not D3, actually, it's more in the moderate aortic stenosis, the valve area of 1.35. Overall, hemodynamics look good filling pressures, good cardiac output. However, the operator opted to use Impella for hemodynamic support of the case, given the complexity of it, the amount of calcium, the need of atherectomy, etc. So he started by performing atherectomy rota with 1.5 Burr. I don't know if this is working or not. Can I see if it works? Okay. Let me go to the next one. Just 1 second. All right. But anyways, so he started with doing an atherectomy, and suddenly the rota stalled and got entrapped. So now the Burr is stuck, is fixed, is not rotating. It's in the mid vessel. There's no flow in the LAD. Luckily, we have the Impella in, still maintaining perfusion. And patient was stable, no chest pain. And this is, so the question is what to do now. And just what Dr. Ahmad Kamel just mentioned, be calm. The worst thing you would do right now is freak out and you don't know what to do. This is where the patient would, want to do well with freaking out. So this is such an infrequent complication that really you have to think about the steps of how to handle it. So the first thing you want to have in your mind is you need to call surgery. You need backup surgery. There's a risk of perforation, loss of flow, all of the hemodynamic instability. You have to involve your surgeons in this case. And if you remember from this discussion, the surgeons were very upset and happy. They said, if anything happens, do not call us. We're not going to support you in this case. If the Burr is still rotating, but it's stuck, you can try putting the Burr on Dynaglide or even like going to higher speed and try to advance and withdraw and be lucky to free it. One thing that can be also attempted is, as you know, we perform the rota on a rota wire. The distal part, the radiopaque part of it is 014, and the body of the wire is 019. One thing you can do is you can pull the wire and try to tug on the wire, of course, carefully. Because the wire is not going to come off the Burr. It can put some pressure on the distal part of it that it can give you some back pressure on it. If this doesn't work, you can consider getting a second axis, putting a ping pong guide, and try to wire next to the burr and inflate a balloon to try to loosen the burr. If this doesn't work, then you move to more advanced techniques where you would cut the shaft, add a guide extension to provide counter traction. In some cases, you can consider using micro snares to increase the force of pull. And as a last resort, you can use your CTO skills, CTO techniques to go to the subintimal space and modify the plaque by ballooning. So again, going back to our case, so the burr is now stalled, no flow. So we got another guide through the impeller sheath. We did the ship technique. And it was relatively not the smoothest wiring, but we were able to get a Fielder XT next to the burr. However, nothing would cross next to it. We tried the microcatheter, we tried the smallest balloon, a 1 millimeter balloon, but it would not budge next to the burr, so that really technique did not work. So what we ended up doing is basically we wanted to advance a guide extension over the rota shaft. And the way you do it is you cut the rota drive shaft just distal to the advancer. You take the sheath out, so now you're left with the rota floppy wire, which is inside the rota sheath. And then over that, you would advance the guide extension. I use the 7 French in this case. So I advance it as far as possible that I can get it close to the rota. Even with that, a lot of pulling, it would not come back. It was just stuck in there. We were really not sure what we can do right now. I mean, I thought like we're done. I don't really have any other options. So, and what we thought about is trying a micro snare. So we used the 4 millimeter micro snare. We advanced it over the rota drive shaft and got it so close to the burr. And then with the guide extension and pulling on the micro snare, you'll see here towards the end, just the burr popped back, and we were able to get it back in the guide. And on top of this, you see also I was pulling on the guide wire, the distal part of the rota wire, which is the 014. So we were able to get the burr out, and we still have work. We haven't modified the calcium yet. And one thing about the beauty of using orbital atherectomy, the chances of entrapment are, I don't want to say impossible, but it's much, much lower than with rotational atherectomy. So we changed the wire to a Viper wire. We did a CSI orbital atherectomy. Then we exchanged that with a workhorse wire. And ended up pre-dilating all the LAD, ostial left main, and the ostial circ, and the plan to do a DK crush for the left main. So here you see the first kissing balloon inflation, followed by stenting of the LAD, and another stent all the way back to the left main. We did the POTS and then a second kissing balloon inflation, and this is the final result. So as I mentioned, rota entrapment is really very rare. This is actually the first case that I had to encounter. I've done really hundreds of rotational atherectomy. The key is be careful with it. The reason why it was trapped the first time because of the excessive force that was pushed. As you know, the diamond, the burr has, the front part of it has the diamond coated, which will actually do the ablation job, and the posterior aspect of it, or the proximal aspect of it, is smooth, doesn't do any ablation. So once you cross the lesion that is not well treated, it's very hard to pull it back. So prevention is easier than its complicated management. Some of the things you need to think about when you encounter this, you need to use pecking movement, very slow movement, no excessive force. Get your ears used to the way that the deceleration sound. Try to avoid decelerations more than 5,000 RPMs from the baseline. And overall, this is a very tricky, challenging situation. And if you are doing rotational atherectomy, it's good to be aware of the management algorithm. And thank you.
Thank you, Dr. Hussam. Our next case is a case of PCI complications by Dr. Zaher al-Kasih.
Okay, Masal Khairat. I'm going to talk about a dehisced radio-opaque ring from a diagnostic catheter that happened during one procedure. This is an unusual case of a dehisced radio-opaque ring from the diagnostic catheter into the circumflex artery. Actually, this is quite a rare complication. I could see only few cases from India of the same complication. Now, coronary angiography is the gold standard for diagnosis of coronary artery disease. Though it is a relatively safe procedure, complications can occur. Most complications occur during angioplasty stenting, as the procedure involves manipulation and traction forces. This is a 50-year-old married female patient with a history of diabetes, hypertension, hypercholesterolemia. She presented with chest pain on moderate activity. Coronary angiography revealed long, tight 90% stenosis of the LAD, long, tight 85% stenosis of the circumflex OM, and long, tight 80% mid-RCA stenosis. Then 4 drug-eluting stents were implanted, 2 in the LAD, 1 long stent in the circumflex, and 1 long stent in the middle segment of the dominant RCA. This is what we did initially, and the patient was put on Plavix, aspirin, simvastatin, an ACE inhibitor, metformin, Actos, Amaryl, Concor, and lansoprazole. Now, a few years later, she presented again with exertional chest pain and shortness of breath. Coronary angiography showed patent LAD stent and RCA stents, showed tight left circumflex post-stent disease, and focal proximal 70% left circumflex in-stent restenosis. 6 French Judkins left 3.5 diagnostic catheter was used to cannulate the left coronary artery. This catheter was previously used and sterilized using ethylene oxide solution. Now, this is the first image, somewhat dark. Now, this is the second. You could see here at the tip of the catheter, the radio-opaque junction, the radio-opaque ring at the tip of the catheter made a funny angle. And then in the next image, you could see the ring moving. And then suddenly, the ring went into the left coronary sinus. You could see it moving in the left coronary sinus. At this moment, I was so afraid that it could embolize to the brain. But you could see it moving around. And then after that, suddenly it went into the left circumflex artery, just proximal to the old stent. And then after that, initially we had blood flow, and then I looked at the right coronary just to be sure that the right coronary is okay, and the stent was patent with no problems in the RCA. The catheter was withdrawn, the left coronary catheter, and examined. The soft ring of the tip of the catheter was found missing. So 3.5 left Judkins 7 French guiding catheter was used with a 0.014 floppy coronary guide wire, and then I tried to pull on that catheter ring using a 1.5 times 11 millimeter mercury balloon. Went at 10 atmosphere and then higher pressures. I couldn't pull it up, and then I used a 2.5 times 15 millimeter Voyager balloon catheter at 6 atmosphere. And at this moment, actually, we had no flow or minimal flow in the coronary artery. And then I tried to pull the ring into the left main, so I could pull it up. I was making some progress, but no really good progress. And then went with the other balloon, tried to pull it up. I couldn't pull it after inflating the balloon, not to be a very high pressure. So I decided I didn't have a snare, too bad. I didn't have other equipment to be able to pull on that ring. So I decided to stent. I decided to initially balloon the stenosis distal to the stent in the circumflex artery, and ballooned the whole segment. And then I stented the distal segment, then dilated, and then stented the proximal segment. At this stage, the radio-opaque ring now is behind the proximal stent, and then I post-dilated with a non-compliant balloon, and this was the final result with the radio-opaque ring now behind the proximal stent. Now, at this time, multiple manipulations, as you could see earlier, multiple manipulations led to the guiding catheter moving inside the distal segment of the LAD, and many times moving into the circumflex artery. So. As I said, finally, the patient was okay. At many times, she had severe chest pain during the procedure. This is what we ended up stenting the whole segment. So implanted stents in the circumflex were Medtronic Endeavor stents, included the 3x30 proximal and 2.5x 30 millimeter distal stent. And then I used a non-compliant balloon post-dilation. The patient was discharged home 2 days later on the same medications, and simvastatin was replaced by rosuvastatin 20 milligram. 8 months later, the patient presented again with chest pain on ordinary activity and shortness of breath. Coronary angiography revealed severe stenosis of the distal left main, origin left circumflex in-stent restenosis, origin LAD pre-stent, new 85% distal LAD stenosis, occluded distal left circumflex with retrograde filling from the RCA, apical akinesia with expansion, lateral hypokinesia, estimated EF of 40%. And the patient was referred for bypass surgery. So this was the result afterwards, and you could see here the terrible results after 8 months, distal left main, origin circumflex, and origin LAD stenosis. The right coronary was still okay. Now, causes of catheter tip dislodgement include frequent reuse, excessive torquing and damage of the catheter tip during difficult engagement of the left main ostium, poor handling, forceful withdrawal in the presence of stent, polymer aging, and manufacturing flaws. A foreign body in the coronary artery could be a nidus for thrombus formation. It could cause acute occlusion. It could cause myocardial infarction, arrhythmias, dissection, perforation, and sometimes cerebral embolism during manipulation. A foreign body in the coronary artery could be removed by balloon catheter, by snare, by cardiac bioptome, and by twin guide wire technique plus snare. The take-home message: repeated use of re-sterilized catheters should be restricted as much as possible and should be used very cautiously, and always be ready for the rare complication, and have the necessary equipment ready, including snares, baskets, bioptomes, etc. Thank you very much.
Thank you, Dr. Zaher. Discussion. Okay, I have a couple of comments, very quick. Dr. Fadi, we know by the age of 40, 50% of us will have some calcium. By the age of 60, 80% of us, and by the age of 70, 90% of us, we have calcium. So I agree, and the problem with the angiogram, it only shows around 23% of calcium. So we're missing a lot. So Lesion preparation is really a must. And my comment to Dr. Ahmad is, I mean, the balloon pump, we probably should have used it in the beginning of the case, and always the RCA makes a big difference when we deal with left main disease. And I mean, I know we have students and fellows here. You know, the line doesn't end with us. I mean, if a surgeon says he's too high risk and he is so complicated, I don't think I know this is an interventional conference, but there is something called medical therapy. We can't just go into every artery, and sometimes we leave the patients with worse complications than we start with. And the message that Dr. Suradi said, do not panic, anticoagulate. When that Burr is stuck, anticoagulate, vasodilate, and call for help. Any questions?
Yeah, thank you for the speakers. Two mixed comments and questions. The first one for Dr. Fadi about the, we noticed that the main obstacle was the cost, then the cost, then the cost in the choosing the modality of preparing the lesion. Now, is this approach to start, of course, the cheaper will be the balloon, so start with the balloon, then upgrade your cost, let's say, but we know that traditionally it's better to avoid ballooning if you are planning to do the rotablation. So, any comment in this point? The other one for Dr. Ahmad, just quickly, you used the over-the-wire balloon. Was it only as a microcatheter to insert only the rota wire, or you use it for pre-dilatation or preparing? Because then what we just mentioned that the dissection happened, if it was inflated or not, the balloon. Thank you.
Thank you for your questions. Regarding the first point about upgrading the equipment, I find it sometimes 2 points about that. It will add the cost because the other equipments will be higher equipments. عم نحكي عن 500 800 دينار تفتح high pressure balloons. So from the very beginning, just go to the one equipment that will work the best. That's my advice.
Will work.
Yeah. Inshallah. القضية الثانية, usually, and that's my personal approach, I like the rotablation in a virgin artery. مش ملموس بالبالونز. I know many people, they say that you can do ballooning, and if there's no visible dissection, you can proceed with the rota. I've done it a few times, but yet I feel it's much safer to start with the rotablation on a very smooth calcium. You don't run into any entrapment or catching the dissection. The last comment, it's all about discussion with the patient and the family. The reason that I did some of the cases here in Jordan was just discussing with the family, explain for them what we have, and as a community, as cardiologists, interventional cardiologists, if we have a unified message, that will sync with the patient and understand why we are increasing the cost for these procedures for better outcomes.